University of Maryland, Carol Horvath, when he was studying an autistic child. The child had unexpected behavioral improvements immediately after the secretin. There have been several, maybe a dozen, published clinical trials of secretin. The secretin has not been a lavish therapeutic success. The FDA gave it fast track. It just didn't pan out. The improvements reported in about a third of the case of the published studies don't persist. Don't seem to be enduring. But one of the interesting points here is that it did change the kids. The behaviors really improved, if albeit temporarily, in many of the kids. And the highest binding when you gave the IV secretin experimentally to animals was found to be in the NTS. In fact, if you give the secretin intraventricularly, it binds the subregions of NTS, which I have dubbed PNTS, or permissive NTS, specifically. And then the parental reports of potty training after secretin meant something to me, too. The kids their speech would turn on temporarily, but the moms would also say the child now potty trained very quickly, as if they could sense the presence of feces in the bowel. There was a really precise and exquisite thalidomide publication in autism, which has withstood scrutiny. It's accepted as part of the truisms in autism. It found that thalidomide exposure during gestation, human gestation, definitely associates with ASD, but only if the exposure occurs between 20 and 24 days. Only 20, that's a critical period. Doesn't happen outside that. And which in rats corresponds to days 11 and a half to 12 and a half, and fibrillar acidic protein. And the area between the dotted lines, which has both floor-gold and glia, is where the hypothesis says autism is active. The so-called permissive NTS. There are two subnuclei of this part of NTS which act this way. The dorsomedial aspect, which would be up here, has been shown in prior publication to not have blood-brain barrier. And then the commissure part of this NTS down here acts like it doesn't have blood-brain barrier. They're tight junctions, but it's probably axons from the AP. So you get significant uptake of the fluorogold there too. Ionic mercury, it does get in the brain. It does cause significant clinical disease. Pink disease from 1890 to 1950, which if you look at its clinical presentation, loss of speech, loss of social, looks an awful lot like ASD. But pretty well went away after the world quit using the mercuric chloride teething powders to quiet the fussy babies or toddlers with teething. And of concern in food, air, water, and soil. There's some articles on that. These are the accumulations of ionic mercury are ongoing. And the heck of it is that in the CBO, it associates with increase in microglia, and it persists. It's detectable both as an increase in microglial activity and also just presence of cation for really the life of the animal. The hallmarks of ionic mercury and contact with brain are inflammation and autoimmunity. If you give organic mercury, methyl mercury, the kind in fish, and every day, orally, to rats, and then measure accumulations of the ionic form of mercury, which organic mercury gets pretty rapid conversion, especially, and that's a function of methylation status in part. If you measure the inorganic mercury, which has been derived from the ingested methyl mercury on a daily basis to laboratory animals, you get very significant increases in brain levels, times 30 at 6 months, times 60 at 18 months. Some of it will get through areas of brain protected with blood-brain barrier, but to a much lesser degree than in the one CVO, which this study by Botter examined, and that was the pituitary, posterior pituitary. The only CVO examined had by far the highest retention of ionic mercury. And if you terminate administration of the methyl form at 6 months, the ionic form continues to accrete in the pituitary. It doubles again. It redistributes from the rest of the body. Cadmium injections accumulate only in the CVO, in this case, AP, erythropoietin, and pineal. It's strongly oxidant and is blocked by antioxidants, and it's highly inflammatory, and perhaps significant to the A2 part of the hypothesis, it strongly inhibits norepinephrine uptake. Paraquat accumulates only in the CVO. I don't have any data here for accumulation in NTS. As far as I can tell, it hasn't been done. Oxidative stress, but it's predictable, I think, given the anatomies we know. TNF alpha production, including LPS-stimulated monocyte TNF alpha, go 18-fold after treatment with Paraquat. Monosodium glutamate, which is just ubiquitous and increasingly so in the modern food. Injections accumulate only in the CVO, AP, and median eminence. And it has a persistent oxidative effect associated with TNF alpha and neuronal cell death. And here's what you get when you give mature animals MSG. And it's the permissive NTS there, the white zone, that has virtual eradication of neuronal populations. There just aren't any neurons left there. Endotoxin induces the robust release of TNF alpha, and it spreads. It may start off early, say 1.5 hours in the NTS, but then it diffuses, presumably, and is marked by 18 hours. While in the adjacent dorsal motor nucleus of the vagus, no TNF at all until it appears finally at 18 hours. But it does disseminate from an epicenter. And these slides show, I don't have any for the NTS or the AP, but I do show median eminence with uptake here. This is LPS and TNF and eventual dissemination, diffusion presumably into adjacent areas. And this is the subfornical organ as well, which demonstrates the same phenomenon. Chelation is a really controversial term. It's really hard for physicians and even basic scientists to talk about chelation because it's become so controversial. It just about gets you kicked out of the doctor's lounge if you even mention it. But DMSA, dimercaptosuccinic acid, is an oral agent that's approved for pediatric lead poisoning. And it also increases excretion of cadmium and mercury. And it's known for sure that DMSA is too ionic to pass the blood-brain barrier readily. It just really very poorly transits blood-brain barrier. And yet we have two published studies, both of them controlled, one of them double-blind, one from Arizona children with ASD, and the other Egyptian children with ASD. And both of them showed significant behavioral improvements in ASD after administration of oral DMSA. Now, these are preliminary studies, but there are two of them, and they had consistent findings with pronounced effects on verbal communication and taste aversion. I don't know if I have a slide for it, but there's also documentation for taste aversion in association with ASD.
So the really big elephant that appeared in my study is this one. And it wasn't an elephant. It was a little boy who came to me from when I was in clinical practice down in Tucson, Arizona. And he came to me from Los Angeles. And here's his story. He was a brilliant little 4-year-old. He was bilingual in Spanish and English. He was going to be an honor student like his older sister. His problem is he had lots of dental caries. At age 4, they took him to the dentist, and this child is so good and so mature and so controlled that they were able to place 6 amalgam fillings, including 2 baby tooth root canals, which are really deep, way into the root of the tooth, with local anesthesia. 6 of them in one sitting. And he became somnolent for 2 days immediately after the procedure. And there was a social and vocal decline over about 2 months. And I examined this case like a crystal. I looked at every facet of this case. I know this family so well. And part of the pertinent history here seems just like subjective, but I think it's important. The mom said that this child's last words before total termination of speech was in a whispered voice. They noticed a decline in the volume of the voice in association with the loss of words, less talking. But his last statement to his mother, if you can believe it, was a whispered, "I am shouting." This is a 4-year-old boy who I think represents a self-report on what it's like to have a vocal regression in autism. And at 5 years, remember the whisper there, and I am shouting. 5 years, that happened at 4. And you're not supposed to call it autism. You don't put it on the ASD spectrum unless it's within 2, now maybe 3 years of age. So this was a little too late. So they called it at 5, they called it Landau-Kleffner syndrome. Close enough. It's on a spectrum, if not the ASD spectrum. And the psychometrics for this child are just like a kid with regular, before age 2, autism. Few words, touch and sound sensitive, poor social. I did the psychometric testing in part myself, except for age of onset, the kid's ASD. 6 years, more alert and talkative temporarily after he got IV secretin. 6 years, 8 months, he's slowly built up to reclaiming about 100 words vocabulary, a small percentage of his previous capacity before he lost his verbalization. But he'd improved, and they were doing a lot. They were identifying and addressing nutritional deficiencies and microbial overgrowth. They were trying a lot of things, behavioral therapies, and they worked this child up to a more functional approximation of 100 words. Came to me, and he had high levels of mercury in multiple tissues here, serum, hair, urine, and the lymphocytes on a memory lymphocyte immunosensitivity assay from Stockholm showed he was very sensitive to mercury. Age 7, the parents on their own volition, and the parents really wanted me to popularize this case. They wanted me to tell people about this case. That's why I published it. They took him to a second dentist, and without precautions, no well, no high ventilation to draw off the mercury vapor from all the grinding, without precautions, without any DMSA perhaps before, or DMPS before the procedure. These are all done, by experienced clinicians who are supervising removal of amalgams when they think it may be indicated. Without precautions, this child suffered another calamity. He quit talking. That night he said Band-Aid. That's all he said. And he was totally mute within 48 hours. It all went away again. A year or so later, they tried DMSA on him, and he seemed to be more alert and cheerful, but not much improvement. And when I last saw him at age 16, he was low function, really low function. The second one was too much. Surprisingly good at the keyboard. A nonverbal child, and the first question they asked him on the keyboard was, who was president? And he had it. Obama. Case study. RK. I think it's consistent with amalgam regression. It wasn't the anesthesia. The first one was under, if you assume that the first slow regression over 2 months that followed temporally, the placement of the amalgams originally, that one was under local anesthesia. Cancel that with general anesthesia for the procedure of removal. Amalgam mercury circulates primarily in the ionic form. We know that. And then we asked the question, what about this whisper? Does that associate with regression? And of course, we found the answer I outlined in my first talk. Amalgam removal, it decreased plasma and red cell ionic mercury levels by 73%. There should be a concomitant increase when you put amalgams in. And there's the database finding, which shows that, and this is ripe for somebody to really prove, with a systematic study. But it would appear that whisper does associate with vocal regression autism, and we have some explaining to do, and it's a clue for the hypothesis. Because it's found that if you surgically deafferentate the larynx, just remove its sensory, interrupt it, divide the nerve, you get severe vocal impairment in primates. And then further, the studies by Clarence Sasaki about it back at the Yale University ENT shows that you get reduced glottal closing force. You can't tightly close the vocal cords if you decrease the sensory, the afferent flow. So unilateral division of the superior laryngeal nerve in his porcine cohort, just unilateral division of that nerve, which is almost all sensory, gives you a 43% in the glottal closing force. And then in a subsequent study, he showed that if he just raised the core body temperature up to 101 degrees, you restore full glottal closing force in these animals. Big deal in the context of autism, because it's been known forever that when these kids have fever, when they have a febrile episode from infection, many of them become quite lucid and vocal. And the Johns Hopkins University published a study on this finally, which corroborates that parental observation. I find it of some interest that temperature-sensitive vanilloid receptors in the afferent terminals of the NTS at the level of the AP, in other words, the PNTS, are temperature-sensitive. They're activated by. And this is how Clarence Sasaki measures that reduced glottal closing force. Parkinson's, I went shopping in the Parkinson's community. My primary research arm is Veronica Miller at the Wadsworth Institute in New York. She's Parkinson's. And she pointed out that toxins are suspected as an underlying influence in Parkinson's. Inflammation is prominent, and that they have lots of GI symptoms in Parkinson's. The glottal closing force is decreased objectively, and Parkinson's commonly associates with whisper. And the further relevance here is that dorsal motor vagus, immediately subjacent to the NTS, is proposed as the first site of pathology in autism. Brock is the one who's published on this and describes a ramifying pathology of Parkinson's disease, which I think may be germane to autism. So afferent block at the NTS alters visceral function. That's a really important concept. Experimentally, if you deafferentate the gut, either mechanically or chemically, say selective vagotomy at the nodose ganglion, just take out the sensory, you get decreased gut secretory function. And then if you microinject the PNTS, you get decreased gastric motility, which might be enough to explain the esophageal reflux that's seen in 2/3 of these kids, and why taking them off of casein, an opioid, seems to help about half the kids. Splenic deafferentation in this one study showed that these were vagal nerve studies, VNS studies, vagal nerve stimulation studies, which use vagal nerve stimulators in acetylcholine knockout animals, demonstrated that interruption of splenic afferents shifts the lymphocytes to pro-inflammatory setting and increases TNF alpha. And the PNTS, not the specific subregion of NTS that I'm suspicious of, has significant effects on cerebral blood flow. It's the commissural subnucleus there, which in which stimulation increases cerebral blood flow. And it may be why we have reports, published reports of significant improvements in vocal function and other behaviors in children with ASD who have implants, VNS implants for intractable seizures. Lesions of the PNTS block the baroreflex rapid adjustment of pulse to blood pressure, and experimental lesions block autoregulation. And I went through, with some trepidation, all the literature to see if I had my viscerotopy right. Because surely, if I'm talking about this tiny speck of PNTS, I better have viscerotopic representation for these viscera. And in fact, it's the PNTS, one or both of those subnuclei, which have viscerotopic representation for baroreflex, autoregulation, stomach, intestine, and larynx. And multiple references are found in my hypothesis article cited there. The only one I can't find, and I don't think it exists, is the viscerotopy for spleen. Don't have that. I don't know where that is. I don't know if that's been studied. Experimental lesion of the PNTS increases salt and water intake as documented in ASD. NTS has borderline circulation. Localized infarcts in both adults and infants after hypoxic or hypotensive events are described. Strictly limited to the NTS. If you completely infarct out the NTS, it's terminal. You die. But I think we have something very much short of complete infarction. I think we're going to have functional impairment of NTS. And there are published studies now showing quite a large series of localized infarcts in both children and adults after hypoxic or hypotensive events. The apparent sensitivity to hypoxia, ischemia of the NTS, and I'm talking specifically of PNTS now, may have to do in part to a high concentration of NMDA receptors found in almost half of the neurons of the NTS. That, of course, confers enhanced hypoxic sensitivity. There's also measurably lower capillary density than adjacent areas, and there's a unique blood supply which features reentrant blood from the area postrema. This is from a Hungarian study from several years ago, which shows the hypovascular PNTS, I think, pretty graphically. There's just more white there in the midline. You see, in the neurodevelopmental sequence, the NTS and anastomosis does not cross the midline. It does not cross the midline. You really got end vessel blood supply there. And the arrows here, which are from the Hungarian article, are these unusual appearing venous contributions, reintroduction of venous blood, which has a very, very long residence in the AP, reintroduction to the PNTS. Acetylcholinesterase, which because of its effects on nitric oxide has a profound pro-dilatory effect on small vessels of the brain, is especially enriched in the PNTS, and as the second reference shows, is subject to reduced amounts or activity in association with ionic mercury, cadmium, MSG, and nitrate. Oxidative stress increases blood viscosity. We have one study which shows that freeways and ASD associate, and we may have a contribution of carbon monoxide, potentially. The spontaneously hypertensive rat, SHR, is emerging as a model, an example anyway, of focal inflammation of the NTS. Patton from the UK is showing that there's the NTS in the spontaneous hypertensive rat, which, by the way, is breathing the same air that our kids do, and which are not hypertensive until adulthood. They are exists. There's an ischemia and a hypoxia, of course, is known to result in microvascular inflammation. Marked inflammation, high pro-inflammatory JAM1 is found in the NTS microvasculature of the SHR. And a potent vasodilator measurable peripherally, CGRP, is really increased profoundly in both the SHR and in the heel bloods of neonate humans who later eventuate the diagnosis of ASD. Is NTS a cytokine epicenter? I think so. From the accumulation of toxins and or ischemic injury or ischemic impairment. And there are two references here for how the cytokines from an epicenter, such as the NTS, might propagate to other areas of brain. I don't know what the latest thinking is about TNF diffusion along small channels along the myelinated axons, but I think it may be why we explain this, if not just on the basis of much increased systemic oxidative stress. There is a strong epidemiologic pillar in ASD for fetal hypoxia and events which associate, especially during labor and delivery, with ASD. Fetal distress, prolonged labor, cord complications, low APGARs, C-sections, these have all been reported to increase the incidence of ASD, as do low fetal pH and newborn encephalopathy by objective measures, times 6 incidence. The A2 neurons, which contribute to this ascending noradrenergic system, I'll show you in a moment, are also preferentially sensitive to hypoxia. And it's this noradrenergic system which is so important in the expression of affect and social behavior and learning and sickness behavior. Linda Reinemann is the one who's written a review on this and the one who contributed the pretty slides. These cells, of course, produce norepinephrine, which is found to be compensatory in conditions of ischemia and excitotoxicity. The clinical response to clonidine suggests a central norepinephrine deficit in these kids. And clonidine is known to act at the NTS to increase vagal tone. Selective sensitivity of the A2 to hypoxia. Hypoxic insult may depress vasodilatory adenosine, which is much enriched in the PNTS. Hypoxic ischemic rat pups have decreased numbers of A2, persistent in adulthood. Neonatal asphyxia experimentally has persistent changes in A2 function. And perinatal MSG depressed the norepinephrine production from A2. Long-term, no morphologic change. A pretty slide here, which shows the stain. The red stain is for dopamine beta hydroxylase, which will identify the A2. And Linda was somewhat surprised to see these A2 in the erypostrema. She wasn't sure that those had been described before, but that's the erypostrema there. We've still got the green for fluorogold uptake. The fluorogold doesn't cross blood-brain barrier readily. And the commissural and dorsomedial subnuclei, which form what I call the PNTS, in here with both the green and the red elements. And I'm worried about the red elements in the PNTS. I must, here in my closing minute, say something about vitamin B6. Bernard Rimland championed the use of B6 clinically, and it really does help these kids in about 50%. I would say 50% of kids get better, and there's several tight studies reviewed by Bruce Ames, which strongly suggest therapeutic effect from B6, but you don't know why. And one of the potential explanations here is that cystathine beta-thionine synthase, which B6 dependent and heme dependent enzyme, is an alternative pathway for the generation of hydrogen sulfide. And it's hydrogen sulfide which increases afferent transmission in the NTS. Go you, Bernie. Potential treatments, maybe detoxification. We've got the Egyptian study. We've got the Arizona study. Maybe it's that. Immune modulation, regenerative factors, growth hormones. This might even be accessible for stereotactic application. A very precise delivery to the PNTS eventually. One might dream about that. VNS, the vagal nerve stimulation, including the auricular VNS unit, which is being tested now for seizure suppression in Germany, might be applicable. In Oriental medicine, the amnion point, there's an amnion point which is apparently felt to stimulate NTS function. And then the NTS studies, which I'd most like, are what appears to be working clinically. I'd like to see those parameters studied in association first of all with the electrical studies, which reflect NTS function. Morphologic studies, receptor density, I'd like to see oxidative modification. There's not a lot of this part of the brain available for study because until we intervened about 3 years ago, all of the brain stems were being transected down the longitudinal midline. And we lost the part of the brain that I'm interested in. But time is going to fix that. And we're eventually going to get that tissue, cytokine levels. We did start harvesting vagus nerve segments. And it's elements that the hypothesis is pretty simple. Toxins and or hypoxia contributing to NTS impairment anytime along the neurodevelopmental sequence to result in both ASD visceral and ASD behavioral presentations. And so maybe when you get home and you're driving back to your house, you'll be seeing this elephant in your rear view mirror. Thank you.
So because we